All right, I think it's 6:31, coming on 6:32. Good morning, everyone. My name is Tim Sell. I'm a researcher at the Musculoskeletal Institute here at Atrium Health. I'd like to thank you for getting up and getting online this morning. Today's lecture is part of a series of lectures of what I hope will be a quarterly series of sports science lectures and talks hosted by Atrium Health's Musculoskeletal Institute. And this is really part of a larger initiative to integrate musculoskeletal research across our new enterprise, Atrium Health, the Musculoskeletal Institute, and Wake Forest Baptist Health. And I'm one of two co-chairs of the biomechanics subcommittee that also includes Dr. Kristen Nicholson. I'd like to thank Drs. Carrie Danielson and Dr. Seymour, who kind of heading up this initiative for integration across our enterprise, and Dr. Moorman for their support and endorsement of this initiative. Susan Colston is helping and with coordination logistics this morning. Susan, thank you very much for doing this. Before I introduce our guest lecturer, I'd like to provide the format for today's lecture. So first, Dr. Grooms will present for about 30 to 40 minutes, and then that'll be followed by Q&A. If you have questions, please post them in the chat. I will be monitoring the chat to the best of my ability and copying down some of those questions that I'll ask afterwards. And afterwards also, there will be some opportunities to ask live questions during his lecture if you'll mute. And then afterwards, when we open up for Q&A, I'll start with some of the chat questions. And then when I'm done, we'll take the live questions. And with that, I'd like to introduce Dr. Grooms. Dr. Grooms' initial training is as an athletic trainer. His training was at Northern Kentucky University as an athletic trainer and also mathematics. Following that, he was an instructor at Mount St. Joseph's College in Cincinnati, strength and conditioning coach and athletic trainer and instructor there. I suppose that would mean that he also enjoys Montgomery and Ribs, Grader's Ice Cream, Skyline Chili, and a few other things in Cincinnati. I grew up not too far from Cincinnati, just north in Westchester, Ohio. Following that, he got his master's of science and kinesiology from the University of Virginia, and then went to The Ohio State University to get his PhD in health and rehabilitation science. And I will post some links to to his faculty page and a couple other places in the chat here in a few seconds. He does have I believe you have an NIH grant, R01 grant, to study what you're going to be speaking about today. His current position is as an associate professor of clinical neuroscience in the Division of Physical Therapy at Ohio University. And he lists his current main research interest is how the brain and movement mechanics change after musculoskeletal injury and therapy. And his title of his lecture today is Neuroplastic Optimization of Musculoskeletal Injury Rehabilitation. With that, I will hand over the mic, so to speak, to you.
Thanks, Tim. That was really good introduction. Thank you. Very thorough. Okay, can everyone see my screen? Great.
Yes.
Thank you, Garrett. Thank you, Tim. Thanks for letting me know. And then I assume the videos are playing. Okay.
Yes.
All right. Awesome. Thanks. So thanks for that great introduction. I understand you know your geography by food, Tim. That's probably the best way to live life. So always impressed. This is our campus. We're in Southeast Ohio. We were recently awarded a R1 status. My understanding is because they moved the bar on that, but we're mostly sort of a mixed research teaching institution. And we're in a small town in Athens, Ohio. But if you guys come up from North Carolina there and you ever find yourself a little lost in Appalachia and you end up here, don't hesitate to drop me a message. I'm more than happy to show you around. And I always need more brains to scan, so you can help with the science. I do like to thank Tim. So it's sort of amazing to be doing this, because I remember reading a lot of Tim's work when I was a PhD student, even as an athletic trainer. So it's an honor to present today and discuss how far orthopedics have come in appreciation of the potential nervous system cascade related to injury. And importantly, what I'll talk about today in the last half is what you can do as a clinician to try to improve your therapy by a better understanding of the nervous system. So what I'll talk about today, I'm going to try to convince you that non-contact injury is much more than a musculoskeletal or structural problem. It's actually a nervous system coordination error. And while most of my talk will discuss our post-injury data, if you have questions, we've recently published a few papers and have some more data and review on prospective data before injury occurs that indicates that we need to consider the nervous system in sort of our model of injury prediction. I'll focus on some of our prior data and some stuff that's still in review, some new data on the neural compensations after injury. And then the last half of the talk, I'll sort of give you a rundown of everything we've been testing in the lab to try to fix some of these nervous system problems we see after injury. And so, like I said, I'm going to try to convince you that these injuries, especially the non-contact mechanism, is probably the origin of them is in the nervous system. So you look at this professional golfer, hopefully that comes through over Zoom okay, but you can see he dislocates his ankle and then relocates it. So you have a professional athlete who's clearly coordinated enough to hit a hole-in-one on the PGA Tour, and he can't basically walk backwards without making this coordination error. So he's clearly not fatigued. He has the strength to hold his ankle in place. So this just leads you to a question of why would our nervous system let you down in this way? Why would your joint go into a position where the muscles are unable to generate enough force to prevent a total ligament rupture? When you think about the physiology of this, it seems like it's definitely not going to be something that is a created or an evolved response. So clearly something happened in the neural programming of emotion you've done hundreds, if not thousands of times in that instance where you overload your ligament and it's unable to handle it. But a lot of these people clearly have the muscle strength to absorb the landing, but they just fail to do so. So this further indicates that these sort of non-contact events, something else is going on that we probably haven't been able to measure. And a lot of the data I'll talk about today is not just ACL injury, which is sort of the model we use in our lab. This actually applies to any painful joint. So we're seeing data with shoulder instability, ankle instability, low back pain. This similar neuroplastic cascade is occurring after a lot of these injuries, and the neural factors that predispose people to these injuries are also quite similar. And the classic way to study musculoskeletal science and orthopedic injury has been to use biomechanics. So this is our lab at the university where we can put the markers on, which have become pretty ubiquitous with the study of biomechanics, so we can get an idea for how people move. This technology is spectacular. It's extremely precise. You can measure to a tenth of a Newton how people are loading their joints, hundredth of a degree of range of motion. It's sort of spectacular system in terms of its sensitivity and accuracy to quantify movement. We've made a lot of gains using this technology. We have a much better understanding of the movements related to injury recovery, how people move that predispose you to osteoarthritis, what movements are related to injury risk. It's also greatly informed surgery. If you get a chance, medical history has sort of become a hobby of mine that I read when I have a little bit of time, and especially science history. And if you look back at some of the old orthopedic surgical procedures and how we evolved to where we are today, like the history of arthroscopy and the considerations to do an anatomical reconstruction as opposed to just moving tendons around and all these different procedures, it's sort of fascinating that I think a lot of us like to think we're in this sort of advanced age of medicine and science, and it's only been not even a lifetime where some of the procedures were truly out there and not evidence-based. But biomechanics has really given a lot of insight into the design of a lot of surgical advancements. Some of the early biomechanical studies for anatomical reconstruction were actually, they had the cameras were in the surgery suite when people were practicing and trying to get a better understanding of where to place tunnels and stuff and different aspects of the surgery. And it's also informed how the muscle activation dynamics change. What you're seeing here is even at 12 months after an injury, to just walk, the muscle synergies are still recovering and they're still changing. And this data here is from Len Snyder-Mackler's lab in Delaware, but it's really pretty ubiquitous across most of the ACL literature, is that despite time and even exceptional rehabilitation, so these patients had actually recovered, excuse me, quadriceps strength, but they still weren't bending their knee. What you're seeing here is their involved knee versus uninvolved, how much knee flexion they're going into. So after the injury, they unload their injured knee as you would expect. They have less knee flexion during gait. 6 months later and 2 years later, they still haven't normalized just walking. So I always find this data nearly unbelievable that you can have a cohort, especially this cohort at Delaware, is highly athletic, who gets exceptional therapy, and we're not even restoring fundamental walking after this injury. And then if you may think, oh, a few degrees of knee flexion isn't very much, but if you times that out over 10,000 steps a day, this probably is why people go on to rapid osteoarthritis. And this last statistic is probably the hardest for most of us here. It's probably why we're all here doing, why we're all in some form of medicine or rehabilitation science, is when I was a practicing clinician, as Tim so eloquently introduced, I was working as an athletic trainer, and I never really planned to do research. But when you work as a clinician, especially in the athletic setting, you start to really get to know your patients. You meet them before the injury occurs. You may be the first person to do the evaluation. You take them to their physician. You do all their rehabilitation. Then the physician writes, progress to return to sport by the therapist or the athletic trainer. And then you do everything the book says, you do what the literature says, you do your return to play testing, and the athlete passes. So you return them to sport. And if they re-injure, especially non-contact wise, I think we have to take that pretty hard, because that means we largely failed them. There's something we could have done to better prepare them for sport, and we failed to do it. And you only have to go through a few of these where you realize that our best practice standard of care is largely insufficient. And so as a clinician, I went to the literature, and you look at Cincinnati Children's Hospital, University of Delaware in Oslo, and an athlete, especially a young pediatric female, but the pediatric male data is not that much better. If you want to go back to high level sport, so you're at the most at risk, which is this young athletic population, then you have about a 1 in 3 shot of failing them, that they will tear the graft or they'll tear the other side. And a lot of the data that says that the failure rate's about 4 or 5% is because it's the population mean, and it's people that aren't returning to sport. But I was very interested in, what am I doing in these individuals that they pass my return to sport criteria, they go back and they get hurt again. And so I started on this journey to try to better understand it. And I started in biomechanics, so that's what people studied in our field. And then after I completed that course of study and PhD, I realized that's not going to answer my questions. So I ended up switching to neuroscience with this idea that maybe it's not the movement itself that is leading to these injuries, but it's how the nervous system is programming and generating that movement. And then if we could someday measure with enough temporal dynamics, maybe we get an idea for the neural computations that led to the injury event. We're not quite there yet. This is probably one of our most sophisticated technologies using neuroimaging, but it has a lot of limitations. But I'll talk about what we've learned from it so far. When you think about generating motor coordination or programming movement, it's important to remember that your brain doesn't work as a series of isolated regions. That's sort of how we teach neuroscience, but it's really not how the brain functions. So we classically may think of motor control as, oh, I just need motor planning in the premotor areas and the primary motor cortex to execute the movement. And that's just not the case. When you go to move, you pull in information from your entire cortex. So like motor memories, motor skills, motor abilities are no different than any other memory. When you are learning a motor skill, you learn it in the full context of whatever is happening. So what you're seeing, feeling, what you're thinking about, your emotional state, they all play into the programming at the motor cortex, at the premotor cortex and the motor cortex, and down to the muscles. If you take nothing from this talk today, I would encourage you to just, when you prescribe your exercise, think about what the patient's going to have to do on the sporting field, or even in their activities of daily living, and think about the neural program that's going to go into that, all the sensory context of that, and then think about how we normally prescribe our therapy today. And do they resemble each other? Your therapy may do a good job recovering quadriceps strength, or the classic deficits we all think about, but is it recovering this neural programming state? And I would challenge that probably most of our rehab doesn't do a very good job of that. This is some of our first studies when we were trying to use neuroimaging to better understand lower extremity motor control in the brain after injury. What you're seeing on the left is a PhD student that I was in school with. This is in 2013, 2014. This was about the height of what we could get the MRI to handle. And the reason for this was if your head moves any more than a few millimeters, then the data is useless. So this is why there's very few labs and very few papers that study the lower extremity with brain imaging. The positives of the imaging, though, versus other technologies is that you get the whole brain and you get very detailed resolution, and you can see subcortical structures. So we can see what the cerebellum is doing, basal ganglia, thalamus, and other things that contribute to lower extremity motor control that you may normally miss with other techniques. So it's a very powerful tool, but it's also very limited. But with this technology, we were able to get an idea of what is the neural activation strategy to generate basic quadriceps-based knee extension flexion. And what this video here is showing, this is an ACL patient in red. This is their brain activation pattern, and blue is a healthy matched control. And so the reason why the data is a little blurry is the fMRI collects the slices very quickly during the functional run. And so this is minimally processed data. So I just like to show this to give people an idea of what the data actually looks like. To an extent, it's still a lot of processing to get to this level. If people are interested, we can go into it. But what you'll notice is there's a lot more red than there is blue. That ACL patient has to rely on a lot more cortical and subcortical and cerebellar activation dynamics that are very different than our control participant, who's much more refined, much less neural activity. And you would expect it to be a pretty low level. It's a pretty basic task. It's pretty easy. It's just moving your shank up and down. And this ACL patient and the ACL data I'll talk about going forward, these are all people that are already returned to sport, that are functioning at a high level, that would pass most of your return to sport criteria. And their nervous system is still not activating normally just to engage their need for this very simple task. And from those data, we found that our ACL patients have to increase sensory motor cortex activity. These were all left side ACLs. The imaging data has some nuances with left and right, so we try to get all the same side if we can. And so this is all right sensory motor cortex. And this makes sense because what we see after injury is that you have that prolonged muscle inhibition where it's harder to generate a contraction. Most of that comes from an immediate spinal cord shutdown of the musculature. So what we see is that the cortex has to overcome that neurologic shutdown. And it does it with just increasing neural drive to the muscle from the cortex. The negative of that strategy is you can only increase cortical drive so much. And normally motor cortex activity scales with complexity. The more complex the movement, the higher the motor cortex activity goes. But if you're already hired to do simple movements, you may hit this ceiling where you'll get a neuromuscular breakdown and lose coordination earlier than you normally would. And we see this along with a decrease in cerebellar activity, particularly in the vermis, where has a lot of sensory cerebellar connectivity there where you can correct for motor coordination errors. So normally for the lower extremity, we want to see the reverse of this. We want to see more cerebellar, less cortex. So for instance, right now I'm standing up and I'm speaking to everyone. I have to dedicate very little conscious attentional awareness to keeping myself upright because my cerebellum is doing all that programming for me. Our ACL patients have essentially exchanged this automatic control strategy with this conscious attentionally driven strategy. The other two regions that activated more, one was the lingual gyrus. This is a really interesting area. It's really one of this first step in what's called cross-modal processing. So cross-modal just means I'm trying to match two modes of sensory information. I have proprioception, or knowledge where my joints are in space without seeing them. Then you have visual spatial awareness, or knowledge where my joints are relative to the world, or by direct attention to the joint, or by actually visual memory or introspective attention to where your joints are in space. So the lingual gyrus, it'll activate if you have visual feedback, but also if you have matched sensory visual feedback. And what the lingual gyrus does, it connects with the precuneus and superior parietal cortex and your sensory cortex, and it tries to say where I visually, spatially believe my limbs are is where they proprioceptively are. So you have this big parietal cortex connectivity where you're trying to integrate vision and proprioception for coordination. So that way you can navigate in the world. We're constantly using those two senses together. Now, if you have more lingual activity, is what we see on our ACL patients, that may indicate a greater shift towards a visual integrative strategy because lingual gyrus is much closer to occipital cortex, and you may be more readily apparent to use visual processing to help you program movement as opposed to proprioceptive processing. The other area that activated more was the secondary somatosensory area. This area helps you discriminate between pain and proprioceptive input. It's sort of a higher level sensory integration region. What's interesting with our ACL patients is they were all pain-free, but their sensory cortex had to do a little bit more work to separate out their movement from pain. And if people are interested, we have some new data looking at the psychological readiness profile or kinesiophobia after injury. And the activity of this region seems very important for people to break this pain memory that they associate with knee control or knee movement. And since then, since 2013, 14, we've done a lot of advances in our fMRI paradigm. So we now have VR built into the MRIs. This took a good amount of time with a company called Nordic Neuro Lab to get MRI safe. Means you can't have any ferrous metal in your device. And now we can give them feedback. We can play sport videos. We can do a lot of immersion. This also helps with fear and claustrophobia. We've done several studies now where we look at precise force control of the quadriceps and hamstrings. So you really can't do a max contraction. It's sort of a limitation of the technology, but you can get very precise, more fine motor control. And then with Greg Meyer at Emory, we've been able to implement MR-safe biomechanics in the scanner to also look at coordination during a little more aggressive movements than just the knee flexion extension. And Cody Chris led a lot of this work, and he's now back in medical school because he wanted to be in school forever. So he did med school for 2 years, then PhD, he's back in med school. But he was interested in, well, what's the patient manifestation of some of this neural activity? And so we keep collecting more and more data, and he found that the secondary somatosensory area and the supplementary motor area, these two regions' activity were related to the IKDC score, meaning 100 being very good and 50 being pretty bad. And what he found was more activity in each of these regions was highly correlated to a better patient-reported outcome. What these two regions do is, so the secondary somatosensory area, this makes some sense because it's involved in internal or a proprioceptive strategy, but it's also what allows you to separate out that pain from a proprioceptive stimuli, which I mentioned before. So it makes sense that the people that may be able to have better patient-reported function, or pain's a big part of it, they're doing a little bit more sensory work to make sure that knee pain and that traumatic knee event doesn't interfere with sensory processing. And then the supplementary motor area is interesting. So this is particularly concerned with trying to program movement relative to proprioceptive or internal stimuli. So these combined indicate that our patients that do well after an injury, they're relying more on a proprioceptive-based motor control strategy or a sensory-based one. They haven't developed more of that visual cognitive compensation we see in the ACL cohort as a whole. And he went on to also look at, well, what about quadriceps weakness? So we know the recovery of the quadriceps is extremely important. And so what you're looking at here is these are people that are symmetric or even stronger on their involved quad. These are people that are asymmetric, not as strong. So these would be people who aren't functioning well here, people who are doing very well up here. The reason why you have a lot of people over one is this was we had the spectrum of individuals. We had a lot of people that are like Division I athletes doing a lot of therapy, and they were a little further from injury up to a few years. And so we had a lot of people that worked really hard and were back to high level sport, and then some people that were not. And if you have a question about the analysis, so this is also controlled for activity level and time from injury. And what he found was that those who had quadriceps weakness, so those who did not recover quadriceps strength, they had almost an opposite neural activation strategy as those who had good patient-reported outcomes. They have relied more on the lateral premotor cortex, which is concerned with programming motion relative to the environment and visual cues. And again, this lingual gyrus came out to be highly related to those that have quad weakness. So what it looks like is that people who fail to recover quadriceps strength, in our current longitudinal study, it looks like if they fail to recover it early, they're going to, every day they go with it, they're shifting more and more to this visually dominant loss of proprioceptive based neuromuscular control strategy. And so you're essentially setting them up to use visual attention and external motor programming to just do basic knee control if you can't recover muscle strength. And Meredith Chaput, who's doing a PhD in our lab right now, she just did a pretty interesting study where she was interested in, well, if we see this shift towards maybe visual attention and visual processing, is there a role for cognition in this, and visual cognition specifically? And what she found was that our athletes that can maintain proprioception, who don't have a big proprioceptive loss, they're compensating with visual memory ability. And then our patients that have good stability, which means they can jump and land on one leg and then rapidly stabilize, so they have good knee stability, they have really good visual motor abilities. This is from the impact test. So ability to hold items in visual memory, which makes some sense for how our proprioceptive tests work. You go to a position, memorize it and go, and then try to reproduce it. Even though your eyes are closed, you can still have visual memory activation to help you hold that in mind. And then visual motor is largely your reaction time or processing speed. So if you can process faster, you can probably stabilize a little faster. And she found that the pathway in the nervous system that allows our ACL patients to do this is largely in the precuneus, superior parietal cortex, which are again highly connected to that lingual gyrus. They're on that cross-modal pathway. And so it seems like this sensory integration and this shift towards a lost proprioceptive strategy and altered sensory activation is really this foundation for our patients compensating with visual cognitive abilities. And so I know I've thrown a lot of neurologic information. In summary, what we see is this widespread cortical reorganization, not only in what's activating, but Cody also looked at how the brain is fundamentally connected, is shifting. And we see this increase in lingual gyrus, precuneus activity. And then also these areas are increasing their activity, but they're increasing their connections and their co-activation with frontal cortical regions, which is responsible for your direct attention and cognitive processing. So this is a more global pathway for our ACLs to shift. So essentially you have this insult where you've lost sensory input to your primary cortex. This causes your higher level sensory integration regions to look for additional feedback to help you program movement. And it gets it essentially from visual and cognitive regions. You really only have two ways to generate muscle contractions, generate motor control. The motor cortex requires some level of excitability input. You only have two paths to get it from. You can get it from afferent input and then sensory processing from your parietal cortex, or you can get it from direct conscious drive, motor planning, and attention from the frontal cortex. And our ACL patients, they're actually using both pathways to try to compensate to maintain motor control and maintain input into the cortex so you can have a level of coordinated movement. And while this compensation is fine, we find that it can lead to a breakdown when we challenge our patients in more aggressive scenarios. So this is why our classic return to sport tests are probably failing us. They are allowing these compensations to occur. And then when they go back to sport, their coordination ability hits a capacity. And then if you've trained someone to use visual cognition to control their knee joint from the first day, it's no wonder that when they have to suddenly direct it to the environment and sport, that it fails. And before we jump to the therapy, I'd like you to take a moment and think about what you're supposed to use visual cognitive abilities for. This is a really cool study that looked at eye tracking during just overground walking. What you're seeing here in purple is where their gaze is, and the blue target is where they're looking. And you'll notice vision is used for about 2 steps ahead. And actually use it to plan even further ahead if you're not on unstable ground. So the more easy the locomotor task is, the longer time frame you will use to plan your movement. You do not use visual cognitive attention to generate muscle contractions, to control your joints. Use it to navigate the world. And this is even more apparent in sport. So in sport, you have constant distractors, constant attentional load, even trying to do activities of daily living. However, if any of you have done rehabilitation, what's your first exercise? Your first exercise is stare at your knee and try to generate a muscle contraction. Or you tell them, keep your knees over your toes. Try to maintain good neutral knee alignment during your exercises. And it's sort of no wonder that we've encouraged our patients to adopt this strategy. The reason you do it is it's very effective. People will move better for you right now in the moment, but you're setting them up to have a neural compensation for the injury, which could pay a cost when you return them to sport. And on our ongoing longitudinal study where we're tracking our patients from the initial injury, I went into that with the hypothesis that the injury is causing most of the neuroplasticity that I just showed you. And we're finding it's probably our rehabilitation is inducing most of it. It's the injury sort of starts this cascade, lost proprioception, increased visual cognitive or visual attention for movement. That makes sense. People sort of get that. You need a certain amount of input to M1, proprioception down. I'm going to compensate with something to keep M1 going, because your patients are still going to walk, still going to do their activities. So you have to maintain sort of your M1 output. But then this idea that you've started this shift and now my rehab is just going to encourage this strategy is something that I don't think we think enough about. And it's kind of no wonder that the biomechanics break down. And then our return to play test, this is probably the most disappointing to me as a clinician, especially if you look in the literature today. It seems like our return to play test, they've largely sort of failed to predict re-injury, especially in elite athletes and the young pediatric athlete, because our athletes that restore, that recover these tests, they still have a reasonably high, I'd say too high a re-injury rate. Now, if you don't recover fundamental hop symmetry or quad strength, then your injury rate risk is obviously higher, but just restoring it doesn't seem to be enough. And this has a lot to do with our typical therapy being overly focused on where your joints are, very much what we call internal or explicit feedback, where you're telling our patients exactly how you want them to move. That's just how I was trained to give feedback, but it might not be the most effective way that leads to transfer to sport. And so to study this phenomena, we engage in 2 large studies right now, where we're trying to better understand this transfer to sport, this sort of last step in our return to play protocols after injury. And normally you'd use the biomechanics lab, it's extremely accurate. And to get around the accuracy problem, working with Greg Myers now at Emory Spark down in Georgia, he used to be at Cincinnati Children's, we've developed this virtual reality simulation where we essentially bring the sport visual cognitive challenge into the lab so we can measure with high accuracy. And in this study, we're comparing our traditional neuromuscular training that we know has reasonable injury risk reduction, but still allows injuries and may cause this failed transfer to sport. In our initial studies, we found that standard training induces increased attentional cortical activity for movement, and it depresses the sensory integration that we would want. And so you start to rely a lot on direct cognitive attention to control your movements. Our typical injury prevention program actually plays into the neural activation we see after ACL injury. And so if our goal is to have a better risk reduction and a better transfer to sport, we found that we need an intervention that reduces premotor motor cortex activation and increases sensory integration activity. So we essentially want the reverse of what our ACL patients look like. And one intervention that we've seen success with so far is to use what we call augmented neuromuscular training. So what you're seeing here is this was developed by Greg. I mostly just study the neuroplastic mechanisms of this training and the intervention and injury risk. And so the 2 R01s are to study the nervous system implications of it, but the intervention itself was developed by Greg and his team. What we found is how this intervention works. It takes the 3D biomechanics data, they wear an augmented reality headset, and it displays a rectangle for them. And the rectangle deforms based on their movement kinematics. So if their knees collapse in, the rectangle collapses in. They load one side more than the other, the rectangle shifts. Now, we don't tell the patient what's happening. We say, just keep this a perfect rectangle. And what's great about augmented reality is you can wear it, you can run, you can do whatever you want in the environment. It's not like VR where you're totally restricted visual-wise. So this allows you to be a lot more sport integrated with your training. And you wear this, and after about 6 weeks, we find our patients move a lot better, especially in that VR simulated sport, because that's sort of our holy grail. We want people to not only move better on a normal landing, but move better in sport activity. And we find that it's correlated with this reduction in motor cortex activity that we've been seeking from before, versus the standard training fails to induce the neuroplasticity we need. Now, this sort of makes sense. If any of you have children, especially young ones, you can ask them, how do you walk? And they'll never go, well, I go into hip flexion, knee extension, dorsiflexion, heel contact. They won't do that. But if you see a lot of therapy after people that are trying to do gait retraining, you get a lot of very precise movement feedback. And the implicit neural machinery is very different than the explicit neural machinery. So when you're learning to do implicit, it requires a very different neural activation strategy. And that's what we're trying to encourage here, because that's how we naturally learn to move. Now, if you don't have that technology, of course, that is rather expensive. Is we've done several studies where we just use external focus of attention. A lot of this was pioneered by Gabby Wolf in Nevada. and it's been transferred a lot by Ali and Anna. They've been doing a lot of work to transfer the fundamental motor learning work into rehabilitation. Now, this is very subtle, where you just direct their attention to the environment, or preferably to the outcome of the movement, where instead of keep your knees over your toes, you point your knees at a cone, keep the bar stable as opposed to keep yourself stable, keep the board flat as opposed to keep your balance. So you try to give them cues, and you're almost like tricking them into moving how you want them to move without them putting their attention on their body. So you can be very creative with this. People use lasers on their shank or on their femur. People use all sorts of signals in the environment. Anything you can do to take their attention off the joint and put it in the world, you'll get a more adaptive neural activation pattern than letting them focus on the joint. We've also done a series of studies where we try to use very low cost virtual reality. So in the image here, she's using the Oculus, which is a couple $100, but we're actually working on a smartphone app that I'll give the link away for free. I think we're pretty close to having it ready, where everything that we try in the lab will be in the app for easy use to use in VR. Some examples are, we use a adaptive roller coaster, so this can speed up or slow down based on the patient's balance. We've done a couple studies with this where we find that this is a lot more perturbating than eyes closed. And so when a patient is having to maintain stability, but their vision is moving, this also activates that cross-modal pathway. So instead of getting a proprioceptive error and reweighting towards vision, now we get a visual error, and they have to rely even more on proprioception. Eyes closed actually doesn't do this entirely, because you can actually use visual memory to help compensate when you just close your eyes. So eyes closed is actually not as an elegant a control condition of vision as we used to think. But this idea where you're throwing visual errors into the system seems to be beneficial to help people progress. It's more challenging, but also it targets that cross-modal plasticity we see after injury. We also use it a lot for early therapy. So a lot of our exercises on the table are pretty boring, but you need to do them because you're trying to recover muscle activation. So in this example, we have the athlete do repeated their straight leg raises in sync with a soccer kick from the first person perspective. This is great exercise that activates mirror neurons, so you get extra neural activation. You get increased cortical drive to the muscle. We also see that our patients will activate their quads a little more because they're stiffening to hit the virtual ball, and they can't even see their knee. So you remove the ability to use directed visual attention on the joint. We've also done some more sport-specific exercises where we'll do tackle or avoidance. So we'll work on double to single leg transitions. Instead of just doing it in the usual boring fashion, we do it in response to avoiding a sudden unexpected tackler. We've also been working on different jump landing studies where we try to trick people. They stand up on the box and they think they're at the top of the Grand Canyon, or they're on top of a building, they have to land. What's interesting about this test is you can identify the people that have a very biased visual strategy for movement. So you don't even really need the MRI to detect some of this. If you can trick people into thinking they're higher up than they are, then you can detect the people that are relying on visual feedback for landing versus those that can employ a more proprioceptive strategy and absorb the landing. Another tool we've been using a lot is, especially in late stage therapy, is stroboscopic glasses. So there's a few companies that make them, usually a couple $100. I have no stake in any company. I would encourage you to use whatever gives you the best deal if you're interested in this. Reason why we like it, don't watch this video if you have a history of seizure or epilepsy, because it does strobe, it shudders. Reason why we like this is that you can do progressive visual knockdown. So normally to try to shift and get this proprioceptive strategy reinforced is you have to do a lot of eyes closed training. That's very limited though, because you can't really run, cut, jump. You're very limited in what you can prescribe. These glasses allow you to have a low level or a high level of visual disruption, and you can do any exercise you want. If you do use them, I would encourage you to make sure your exercise requires your visual attention in the world. You can't just put them on and do squats. Our first study failed to do anything, which makes sense in hindsight that you have to have, if you can close your eyes and do the movement, the strobe glasses won't help you. So this is why they're usually a little better for later in therapy, because you can have them track balls or track objects or do other things. And then lastly, I want to talk about some of the return to play tests we've been using. So our normal return to play is to use standard hop tests. These were done in the 90s by Frank Noyes, and the field sort of been stuck with them for 30 years. And they're fine. They're good tests because they'll tell you if they have a big asymmetry on either side, and you can identify gross motor coordination or performance deficits. Now, the negative, like I've been talking this whole time, is they allow full focus of attention on the movement, and it's not going to simulate the visual cognitive load of sport. And so we're trying to use, these are fit light sensors, but a lot of companies make these now. I don't think I would recommend these. There's a lot of companies are making cheaper, better sensors. I find their hardware and software to not be that useful, but they were sort of first to market. So there's a lot of other companies I would look around. One plus is they have an infrared sensor, so it can detect if you just pass over them, you don't have to touch them. And so I would encourage you to find that feature if you can. Essentially, we've remodeled every single hop test to have a version of visual motor processing. What's great is you get the same distance you've always had, but now they have an element of reaction time that you also get. So now you only get distance, but you also get processing speed. Now, since then, we've modified the test further to control for gaze during the test. And this is due to some very recent data from Scott Montford in Montana and Stefan Botkin, he's now in Colorado, where they've been looking at just controlling gaze during movement or where your visual attention is seems to induce most of the perturbations to our ACL patients, in that you don't even have to have them do any sort of dual task or cognitive process. Most of the performance decrement is just due to forcing their gaze to be controlled. And so we've modified the hop test to control gaze during the hop. So the problem with the original ones was they were all reaction load. So this one was peripheral reaction, and then they jump and you get their reaction time. But once they start jumping, they're done with the cognitive processing. And so in this test, they have to stare at this fit light after they start jumping and tell the examiner what the colors were. And the colors are random every one. And so they do 3 hops, they have 3 colors. So they have to maintain their gaze. And we find this to be particularly sensitive in our ACL data so far. And if you don't have a lot of this technology, you can just stand in front of your patient and just flash numbers at them and tell them to add them as they go, or to memorize the number string. And we find just this very simple perturbation can be effective. What I encourage you to try to avoid, though, a lot of people do serial 7s, or where you count backwards by 7s as a classic dual motor task. That's probably not as effective. The auditory motor tasks don't seem to be as good for our musculoskeletal population. Try to make it visually based, and you could be the visually based attention center if you like. So in closing, we've started this journey I started this about a decade ago during my PhD, and it continues on. And our hope is not to totally wreck your rehabilitation. You still have to do everything you've been trained to do. All the fundamentals are extremely important. But I would encourage you to think about adding this one layer to your exercise. So how you prescribe your strength training, how you prescribe your balance training, your even range of motion recovery, just take a moment and think about if you could augment or enhance it in some minor way where you could target the musculoskeletal deficits you've been trained to, but also appreciate the potential neural deficits. I know I've talked about a lot. It was a pleasure. If you email me any questions or anything, especially clinicians, I'll try to help you. We have a lot of resources I give out. I have a smartphone virtual reality manual, and also a bank of just PowerPoints that are auto-timed to cycle between numbers, colors, Stroop test, all this stuff. So you can just play it on a phone, on a tablet, on a screen, and you could copy paste the PowerPoints to be hundreds long. So you can just have cognitive load instantly if you have access to any sort of screen. And this is my lab now. I'm very fortunate to work with a lot of really fantastic people and students. And these are my collaborators from over the years, and our funding from the Department of Defense and the NIH for making a lot of this possible. And with that, I'll take questions. Thank you again.
Thank you, Dustin. We really appreciate it. Just to give you some quick notes, we are recording this, so in a few weeks, I think Susan will be able to put something together that we'll be able to send out. The links to your research on PubMed and a few other links have been posted in the chat. If you joined late, you may not see that. You can email me those for those links. And just a quick note, I want to thank all of our colleagues. We have our athletic trainers here, researchers. We have colleagues from Charlotte FC, from the Carolina Panthers, physical therapists, Wake Forest Athletics, our orthopedic surgeons, and our sports medicine physicians. So I want to thank everyone for attending this lecture. And with that, I'd like to hand it over to Dr. Mormon, who's the president of the Musculoskeletal Institute.
Thanks, Tim. And Dustin, thanks so much for being our inaugural lecturer for the Sports Science Lecture Series that Tim is starting. And wonderful work you're doing. One question I have for you that Tim and I probably both have in our minds, and we were heavily influenced by Bill Garrett, who was our mentor and colleague at Duke for many years. And I'm sure you're familiar with his work. But when you look at these videos of injury and you look at a lot of the prevention, we're trying to keep particularly our young women out of valgus when they land. And Garrett was absolutely insistent that it was not valgus that caused the injury. And you're probably familiar with that concept too. But I wonder if rather than a mechanical issue, because there's just an association, you can't, I don't care what Bill said, there's an association there, right? So I wonder if this plays into your cognitive motor interaction rather than a mechanical factor when we think about that injury pattern and training people out of it. I don't know if you have any comment on that or if that's even relevant to your work.
No, I think it is relevant. A lot of our work and a lot of the rehab field, like you mentioned, they really focus on minimizing valgus because it's like a modifiable, easily seen target. But you're right. I mean, Garrett and Bruce Binion and a lot of the other people who work on ACL injury, they have compelling data that it's a structural issue, that it's more anterior translation, that it's a failure of the hamstrings. And regardless, I would say, and you're right, valgus could just be like secondary, right? Maybe the ACL ruptures first and then they collapse into valgus, as some people suggest. But almost regardless of what the exact mechanism is, if it's a failure of the hamstrings or the quads to decrease anterior translation, or valgus is the mechanism, they both are neuromuscular control strategies. And I think either way, this cognitive overlay is going to play a role regardless of what the precise biomechanical mechanism is. But yeah, that debate is always riveting, I suppose, between Bill and some of the other, like Tim Hewitt and some of the other guys out there.
And also next, I'd like to hand it over to Dr. Rachel Seymour. She's one of the co-chairs of the research committee with Dr. Carrie Danielson on integrating across our enterprise. And she's also the co-associate chair, co-associate dean of research for the School of Medicine.
Hi, thank you so much, Dr. Grooms. That was really just an incredible talk. And I was particularly struck by how what you're doing in the lab is really being translated into more pragmatic settings. Hopefully technology in the VR space can kind of come down in price and be more accessible. What do you see as the next kind of steps in moving these types of technologies into, community clinic settings for return to sport at lower levels of play?
I love that question because I remember being like a clinician in the audience at some conferences, and you would have a researcher come up. They have a $3 million lab. Like I showed you that augmented reality. I mean, that's a multi-million-dollar project just to get to working, right? It's a team of programmers. It's ridiculous. And I always used to think, well, I can't do any of this. This is ridiculous. And so a lot of our work also tries to translate it to clinical practice. So we have the very expensive high-level augmented reality, and then, well, can I put it on a smartphone? And what do I lose in resolution? But is it enough to still get a positive benefit? And then we try to just do very simple clinician-directed feedback. So one of my students is actually doing a study if we can simulate that rectangle that moves when you move. Could the clinician just stand in front of you and just like do this, thumbs up, thumbs down? And then that tells them good, bad movement, but doesn't exactly tell them what they're doing. And we find that approximates, it's not quite as effective, but it's close enough to be compelling neurologically. And so I think probably Greg doesn't want to hear that because he wants the technology solutions. It's expensive, but as a clinician, I find that to be how it speaks to how powerful the clinician is in the moment. And for the augmented reality, I know they're working on a Connect-based system that you could get very cheap and just have on a TV and a camera, and then you could implement it. And some of the therapists will talk to us like they're always worried, well, you're just going to replace me. They don't even need me to tell them what's good movement and bad movement. I don't think we'll ever get there. But if you could get a package that's a monitor for $50 and a Connect camera down to $50, I think that's very achievable. what would be great is if, because you have this big shift, especially where I am in rural Appalachia, is we have a lot of kids that only can go to PT once or twice a week, maybe once a week or every other week, or even longer, and they're doing a lot of it at home. Like if you could send the system home with the kid and it could track their compliance, but also give them a little feedback on how they're moving. I think that, like you mentioned, Rachel, the cost coming down just opens up the capability to what we can do in it. And getting this behavior change compliance wise, but also in the movement quality could be pretty powerful. I don't know if you have further thoughts. I think it's where we have to go.
So Rachel, I think that was the end of your questions. You're muted if you wanted to. Okay. So we have a few questions from the chat, two from Terry Strickland. And I think the first I'm going to kind of expand. Your cohorts of study presented are all anterior cruciate ligament. Have other lower extremity injuries, and I would expand that to even shoulder injuries, have they been studied with similar deficits in proprioception and visual spatial findings?
Yeah, so there's been more, just very recent, people have published on chronic ankle instability, and you see a similar shift. The ankle is just a little, and the shoulder, we can talk about both. There's a few years ago, there's a group that published a series of studies on just shoulder instability, and they see a similar shift away from a proprioceptive strategy. What's unique with both of those is the chronic nature of them adds this extra layer of like elevated pain processing that sort of even interferes more with the sensory integration neural activity. So on some levels, you actually see this effect amplified where they start to direct even more attention, because if you lost proprioception and you have pain, anyone who has pain, you think about your pain all the time. So the longer you go with pain, sort of the worse situation you're going to be in. And in the studies with ankle, and shoulder, the one reason why they're harder to study is that they're just more heterogeneous. So the ligaments that are involved and the severity of the instability tends to be a little bit tougher, but you see a very similar shift. And if anything, the ankle for postural strategy is even more visually dominant than the knee, just because you rely on it a lot more to maintain stability. And so on some level, even though you're not as highly innervated with mechanoreceptors because you have multiple ankle ligaments for any one of them, the nature of what the ankle does seems to manifest with even a greater footprint in the nerves.
Thank you. The next one is from Chris Miles. First of all, and this is, there's been a lot of people who said thank you for the talk. It's been fantastic. I agree with that. So Chris asked, what role do you see this technology, and I would assume it's kind of the virtual reality technology, has in injury prevention, so first-time injury prevention rather than that kind of that secondary or recurrent injury?
So I didn't present because I wanted to make sure we stayed on time, had time for questions, but we actually have some data where we looked at we were collecting data for concussion, or the group at Children's was, and they had hundreds of athletes that had baseline neuroimaging prior to the season. And I asked them, well, do you have people who went on a non-contact ACL injury, primary injury, and can I look at their brain activation data? Now, they didn't have the motor tasks because that's not what they were interested in, but they had resting state connectivity, which means you just lay in the scanner for 10 minutes and you get how is the brain naturally connected. Give you an idea, like your hand area of sensory and motor cortex, they'll be connected like 0.8, like 0.8 correlation, which means as M1 goes up for your hand area, S1 will go up. So that means the neural activity just kind of naturally moves together. And so you can look at 0 to 1, what's the level of connectivity between any brain region just at rest. And you're like highly trained athletes, they'll have increased sensory motor connectivity. You know, and people who are very low activity, they'll have a little bit less. And so it's a pretty good reflection of sort of your baseline nervous system. And we looked at that data, and the kids that went on to non-contact injury from their preseason data, they had virtually no or even a negative correlation between their primary sensory cortex and their cerebellar curus 3, which is a big part of this cortical sensory prediction network. So what that means is this pathway that we found that was deficient in those that went on to ACL injury is all about correcting for sensory prediction errors. So if any of you ever if you ever go to grab a weight, or say you pick up a cup and it's empty, but you think it's full, but it's empty, so you kind of fly up because you predicted a different outcome, but you probably won't smash yourself in the face with it. You'll engage in an immediate correction for that sensory error before you've even realized it. And then you'll be like, oh, the cup is not as full as I thought. This probably happens in your daily life constantly. You're always correcting for these slight sensory prediction errors. And our kids that went on to injury, they had virtually no connectivity in this pathway. And we didn't have any other data on them because it was a concussion study for movement quality, but we also see a similar phenomenon in people that have coordination deficit disorders. These are kids that are just really clumsy and like slower to development, but they're not like diagnosed with a classic neurodegenerative disease or anything like that. And so this idea that your nervous system and this ability to correct for sensory errors being very important prospectively, I think does give a role for the virtual reality or something to induce visual or cognitive errors in your training, so you can try to target that pathway and get them ready to handle the variable sensory environment of sport and make those corrections. So we haven't tested the primary injury prevention capability of this, but I think there's some compelling evidence to suggest that it is worth exploring.
And I have, there's another question in the chat room from Terry Strickland, but it reminds me of a talk I listened to about a week ago by Dr. Rod Whitley out of Aspetar. It's a very humbling talk, and I'll reference a lot of my colleagues here and one of my colleagues, Dr. Nick Clark from the University of Essex. 20 years ago, we were asking to do posturography and FMS and measuring passive range of motion and active range of motion. And Rod Whitley said, well, at the time, that's what we were supposed to be doing. That was leading edge. And what I see what you're doing right now is leading edge and beyond. But Terry's question was about holograms. So if we go back 20 years ago, yeah, we're doing the right things and we're doing the right things now. And I think you're ahead. Where are we in 10 years past where we are right now? And I know that's asking a lot of you because you are. And I think it's a consensus you and a lot of your colleagues like Ali Gokler and Anna Benjamin then say, you are kind of ahead of where we are right now. So 10 years from now, what is the technology, if you can predict, that we should be using?
So technology, I mean, in 10 years, I would be ecstatic if it was in the standard of care where you had your targets for like range of motion, strength, but we had another column that was neuroplasticity. And we try to target some of these factors. I think a lot of this can be done even without technology. Really good clinicians, they can implement a lot of these concepts. And the technology is just a tool to make it easier or to remind the patient or give more precise feedback. Because I mean, I understand where you're coming from and where Aspetar is coming from with the technology. But I mean, what I see, and we have athletic trainers that have to take a public health class because they're going to a high school where kids might not know how to brush their teeth when they're 14, right? Mm-hmm. So I know technology, we love to talk about in the research space, but like posturography for 40 years didn't transfer to that kid, right? We failed. I mean, it's not us, it's like our system. And I understand it's bigger problems than healthcare can solve. But that's not my first goal. My first goal is to train the clinician who's on the edge with better education and better knowledge so they can implement these techniques with minimal technology. I don't see technology being, I mean, we haven't been able to translate most of that to help the most people. That's not going to make the greatest impact. And I think we get in our secluded walls and we forget that. So that's my number one goal. Now, to answer his question, I know that's a serious response, but to answer his question, to have a little more fun, there is a guy his name Adam Kiefer is at Chapel Hill, who's doing really cool work where he uses VR that maps the space, and then you can induce distractions, you can induce virtual holograms or things in the world, and you can train people in the safety of your clinic with this VR mapped world, and you can induce whatever you want. You can induce all these crazy perturbations, cognitive control, other player stuff coming at them, avoidance, all in the safety of the clinic, and get them prepared cognitively for the load of sport very early. So you could just do your straight leg raise and you could have them in the sport environment doing the exercise. So you can start this very early contextual learning with that technology. And he's doing it with, I forget the VR system, the one that maps the Vive, I think, and that's only a couple grand. So I think it's getting cheaper, but I just don't see technology as the gateway to help the most people right now until something more fundamental changes.
Well, there's a lot of us on this call, and Dr. Seymour in epidemiology and public health, and my father was in public health service and retired. So your points regarding brushing your teeth, I think ring true. Atrium Health has a mission and a vision that means care for everyone. So I think that rings true as well. We have hit 7:30. Dr. Grooms, thank you very much. I know a lot of people are going to be signing off. You've indicated you have a few more minutes. So if someone would like to raise their hand and ask the questions, I'll take maybe one or two. I know you got to head off to teach class relatively soon, but otherwise, thank you everyone for attending. I think we had a wide range of disciplines and across our enterprise and with our colleagues that are some of our partner organizations. Thank you for attending. And again, Dustin, thank you for your talk today. Does anyone else have an additional question?
Just a quick comment. Dustin, I really enjoyed your flyovers in Athens. On a personal level, I spent my summers growing up in Hocking County there in Logan,
Nice.
working at my granddad's drugstore. So great to see that little corner of Appalachia, which is a beautiful place.
That's amazing. It is. It's a little bit of a hidden gem down here. That's pretty cool, man. Hocking County is a cool place.
Oh yeah.
Small world. That's amazing. Thanks for sharing that. That brightened my whole day.